you?
Hi.
Okay. You guys awake? Are you sleeping? What? Okay, I can't sit still, so let's see if this works. Bear with me. Can you hear me? Yes? Yes? All right, guys, you got to wake up. So I'm going to talk to you about Alzheimer's disease among Mexican Americans specifically. No? Oh, man. Okay, so I'm going to talk to you about Alzheimer's disease specifically among Mexican Americans. First of all, thank you for having me and for being awake. This is, if you have questions, don't wait for the end. Just spit them out. I'd like for this to be, if you have them, bring them up whenever they come up. So why am I going to be talking about this particular topic? So first of all, disclosures, funding from the NIA, EPA, state and private foundations. We're going to talk a little bit about three topics: overview of cognitive aging in general, just to set the stage. Some of this has been covered, some of it has not. We're going to discuss why it's important to focus specifically on cognitive aging among Mexican Americans, and some recent information, recent data that's come out specifically on this topic. So, cognitive aging. Many of you have seen this, but I think there's some context. So, the elderly segment of the United States population, global population, depending on where you're looking, is actually one of the fastest growing segments of the population in general. In fact, those 85 and above are the fastest growing segment of the population. Last time I looked, there were nearly 100,000 centenarians. So we're aging, and we're aging rapidly. This is a very important point. Right now, there are approximately 40 million Americans aged 65 and above. An additional 14 million are going to reach age 65 in the next 5 years. So that is just sets the stage for the growing nature of the aging population. And so cognitive aging, Alzheimer's disease, it depends on where you look, what percentage, but it's anywhere between 10 and 15% of those 65 and above suffer from Alzheimer's disease. Age is the #1 risk factor, as you've already been told. However, it's not a straightforward risk. So once you reach the age of 80 to 85, it's almost 50% of everyone walking around has pathology in their brain, whether they know it or not. So it's a very rapidly growing issue. And here, when you break it down by decade, you'll see that advanced age is obviously the fastest, the biggest risk factor. Approximately 5.2 million Americans suffering from Alzheimer's disease. Texas ranks 3 in the United States with regards to total number of Alzheimer's patients in the United States, only behind California and Florida. Florida being because it's a retirement place. However, given that Texas is rapidly becoming more and more of a retirement destination for our elders, this is going to change also. So Texas ranks #3 because of the sheer volume of number of people who live in the state, as well as now more people coming to the state for retirement. Symptoms of Alzheimer's disease. Most of this we've covered, so I'm not going to really worry about this, but it's the same things you've been told before. Difficulty with recent memory, repeating questions, difficulty finding things, getting disoriented, etc. Mood changes, as was recently discussed, can be risk factors for Alzheimer's disease, as well as prodromal symptoms of. In fact, in some patients, quote-unquote depression can be the first symptom of the disease, and what you'll see is these patients withdraw. They may not even tell you they're depressed, and they may not say, I have a depressed mood, but they withdraw. They withdraw from family, they withdraw from friends, and oftentimes suffer from this quote-unquote non-dysphoric depression, where they don't enjoy things anymore, but they still never report a sad mood. However, that quote-unquote non-dysphoric depression has all of the bad outcomes of quote-unquote your classic depression. The big thing to keep in mind, I have people all the time say, well, yeah, I forget names, okay? Have you always been bad with names? If that's the case, then, you know, I'm just not worried about it. For all of you men, raise your hand if you forget your wife's birthday. Come on, nobody, you liars. You know, it's not a change. It's not, so it's things, it's a change in your behavior. If it's different from the past, then I'm going to worry about it. If you're someone who never remembered names, or you never remembered where your keys were, you know, I'm not really worried about it. The next piece is, how does it impact your life? Okay? That is a key thing. The distinction between Alzheimer's disease and mild cognitive impairment is not level of cognitive impairment. Okay? It's functional impairment. All of a sudden, when your cognitive changes impact your daily life, that's when the threshold of dementia comes into play for our diagnosis. So MCI, as was discussed, is this prodromal category. And because it makes sense. You don't just wake up and all of a sudden have Alzheimer's disease. That's not how it works. If your loved one wakes up and now they're seemingly demented, it's not Alzheimer's disease. They've had a stroke. They've had a head injury. They've got something that has happened. It's an insidious process. I need to take one step back, something that I didn't qualify early. I use the term dementia rarely. I'm going to use it today, but to the Spanish speakers, I don't mean it how it comes off in terms of Spanish language. So in the medical sense, dementia means a change in cognition. Okay, it doesn't mean loco. So for those of you who work with Spanish-speaking populations, be careful using the word dementia when you're speaking to patients because you're insulting them every time you say it. So when I work with patients, I never use the word dementia. So MCI, it's one of those squishy concepts, basically, that somebody's memory or thinking has changed. You can notice it, that it's changed. It's not how it used to be, but they still function. Oftentimes it's because they compensate. They use lists. They use planners. They somehow deal with things. Or their cognitive decline hasn't gone so far that they still can't function independently without compensatory mechanism. Here's the interesting piece. So depending on the study, so you can use clinic-based studies or population-based studies. If you want to look at prevalence rates in a population, you want to look at your community-based studies. Anywhere between 10 and 30% of those in a population-based study, 65 and above, will have, quote-unquote, mild cognitive changes. I said earlier, 10 to 15% will have Alzheimer's disease, right? So let's just downplay the numbers and just say 15% and 5%. So that's 20% of everyone walking around in the community has some sort of cognitive issues if they're 65 and above, using conservative numbers. Could be less, could be more. I just say that explains Congress, but not everyone agrees. So the prevalence rates of this it's high, okay? So this is a real issue. There's also a large body of literature saying that these cognitive issues are not diagnosed in primary care settings. So these patients are being seen by primary care docs, healthcare providers, nurse practitioners, psychologists, whomever. They're being seen on a daily basis. But if they're not being looked at specifically for cognitive issues, it's being missed. So oftentimes the family members, by the time they get to someone like me as a neuropsychologist, they're very frustrated. They've been saying, I've got some. Dad's not the same. Dad's memory's not the same. And they've been, pat on the back of the head and said, oh, it's just normal aging. Those of you who have family and loved ones, you're your best advocate. Base rates are, just think, even if you just think 15%, 15% of those 65 and above may have something going on with their cognition. So those of you that are healthcare providers, when someone comes in complaining of it, get an eval. If you're a family member and you're concerned about it, be an advocate until you get an eval. All right, shifting gears. Why is it important, in my opinion, to study this issue specifically among Mexican Americans? Well, that's why. This is the projected growth of Hispanics and all minority populations between the year 2009 and 2050. The green line are Hispanics. So it's expected that the percentage of Asian elders will increase somewhat. African Americans will be almost flat, but increase a little bit. What I don't have is non-Hispanic whites, which does that. It declines. But the population age 65 and above of Hispanics in the United States is going to triple in the next few decades. Despite this, there's almost no literature on cognitive aging issues among Hispanics specifically, which is an issue, and I'm going to explain why I think that's the problem. The other thing, so why specifically among Mexican Americans? 65% of the United States Hispanic population are Mexican Americans. So, it's anticipated that the rate of Alzheimer's disease will grow 6-fold among Hispanics between now and 2050. The recent work, and I know there was a young lady in the audience who asked about prevention stuff, and there's a lot of research ongoing right now on prevention efforts targeting MCI and early stages of Alzheimer's disease. However, there's also recent work suggesting that MCI Alzheimer's disease may be different among Mexican Americans. And this shouldn't be of any surprise because there's literature, huge literature across diseases suggesting that our background, who we are, where we come from, has a tremendous impact on our health. The cancer world has a very well-established literature suggesting that certain drugs work for certain ethnic and racial groups, whereas that same drug doesn't work for others. Diabetes, there are treatment response differences based on diabetic medications, based on ethnicity. So this is an important line of research. So some of the recent work suggests the following, that Mexican Americans may be at increased risk for Alzheimer's disease and MCI. Diagnosed at younger ages and more advanced disease progression. I'm going to go back through these and explain some of this. Less likely to receive formal dementia assessment, longer delays in assessments and treatment, more likely to be cared for at home, which is a fantastic thing oftentimes, but it also has tremendous implications for the community. More likely to present with affective disturbances. Here's a very interesting piece. Less likely to have APOE4 genotype, and more likely to have comorbidities. So why are these particular things important? So increased risk, this is just the prevalence. And so go from one study to the next, and there's just a possibility that Hispanics and Mexican Americans maybe have a higher rate of the disease. I'm not very impressed with that literature, to be quite honest. I think that's a possibility. More than likely, the prevalence rates are pretty comparable. There's absolutely no literature to suggest less prevalent. Okay, so it's going to be comparable or higher rates. But the picture gets a little bit more complicated when we get a little further down. This piece is, in my opinion, one of the biggest issues because oftentimes these patients are being seen by primary care docs. So very few minority patients ever make it to specialty clinics. And it doesn't really matter what specialty clinic or what minority population. Very few minority patients ever go to specialty clinics. They're seen in the community by the docs who are in their community. The problem with that is these patients are being diagnosed later in the disease. So the treatments and the interventions that can help not only the patient, but the families are not being provided to these patients until much later in the disease. So why is that a problem? Well, first of all, patient itself. So him or herself, these drugs, what do? They slow progression. They do not fundamentally alter the disease. I will not tell you that these drugs cure the disease, because they do not. They slow progression. Why is that important? Because if you slow progression earlier on in the course of the disease, you increase quality of life for longer periods of time. As a psychologist, I find that to be of utmost importance. The other piece is that the diagnosis also provides an explanation to families. I have families all the time that don't understand what's going on. What's wrong with dad? Why is he not the same? And it's a lot of stress on the family. When you provide the diagnosis and an explanation for the diagnosis, it can oftentimes set the family at ease of Okay, now at least I understand. I have to deal with it now. I can tell you that I see relief in lots of patients that I work with, but there's also a cloud now. But at least they now know, and they have some sort of understanding of what's going on. This is tied directly into that. But here is another, and this has implications for the community that is of concern to many of us. So the Hispanic, Mexican American in particular, similar to the African American, Southern African American community, much larger family support systems, family structure, family dynamics are very important. And so what happens is the family takes care of the family. With Mexican Americans, the problem we're running into from a societal standpoint is it's normally the daughters that are staying at home and caring for these patients. So now you've got a lot of young women who are being taken out of the workforce, and they're not capable of helping contribute to the family income. Many of them are not finishing school, or they're starting some sort of secondary education and now they're having to stop. So this has societal implications that need to be addressed. The affective disturbance was discussed earlier, so I'm going to focus on a different form, and I'm going to focus on depression. We have data now across 3 independent cohorts looking at Mexican Americans showing that whether you look at normal cognition, mild cognitive impairment, or Alzheimer's disease, the prevalence rates of dementia, of depression, are always higher among Mexican Americans. Always. And we're seeing anywhere from a 2 to sometimes 4-fold increased risk or increased prevalence of depression. We're seeing tremendous amounts of depression in our patient populations. This is a big deal. Why? Depression increases risk for Alzheimer's disease and increases risk of cognitive dysfunction. It's also a modifiable risk factor for cognitive decline. If you can identify who is at risk for cognitive dysfunction associated with depression, you can intervene. And that's some really, actually just got accepted for publication, some new work that one of the folks in our group has identified exactly who with depression, what's the type of depression that increases risk for cognitive dysfunction. So we're going to try and work on that. But here's a piece that's going to drive some of what I talk about now, as well as, unfortunately, you guys are cursed, you have to listen to me twice today. But there's going to be, this is a piece of what I'm going to talk about in a few later on also. ApoE genotype. This is by far the strongest genetic risk factor for Alzheimer's disease. Now, does it mean you're going to have Alzheimer's disease if you have 2 copies of the ApoE4 gene? No. Okay? Does it mean you're going to not have the disease if you have no copies? No. However, it is by far the strongest genetic risk factor. Here's a very interesting piece. In our work, ApoE4 genotype is about half as prevalent among Mexican Americans as it is among non-Hispanic whites. And I'm going to show you some data on this in a few minutes. So, this, combined with that, is a bit disturbing. So we have less frequent, the most common genetic risk factor for the disease, with comparable rates of the disease. So to me, what that suggests is that the underlying issues driving the disease may actually be different. So here's some data that we have. So let's see, yeah. So here's your ApoE 38. Now, any of you have ever seen an Alzheimer's disease study research manuscript? If you ever can get one, go grab one and pull it out. This is what you're going to see. 60% of Alzheimer's cases, minimum, are going to have ApoE4 genotype. If you go to the ADNI study, it's around 75%. That's the biggest, most comprehensive study of Alzheimer's in history. 38% of the Alzheimer's patients in this sample have the ApoE4 genotype. 19% among normal controls, 23%. Here's another interesting piece. 46% depressed, 44% depressed, 21% depressed versus 18, 29, and 10. So you can see very clear issues here. The other piece that is of consequence is this right here. 62 years old, 74 years old. 10 years difference in first noticing cognitive dysfunction. So, there's a huge literature, as Dr. Salazar pointed out, characterizing mild cognitive impairment. Our group this year, actually, we've had about 3 articles come out in the last few months. We've learned recently, actually, I was telling Dr. Baldwin, showed her earlier, someone told me if you do Google search Mexican-American Alzheimer's disease, almost all the hits come up are from the Texas-based work that our group's been doing, which is really pretty cool. But what's the ratio, what are the risk factors for mild cognitive impairment among Mexican-Americans? So, there's a huge literature suggesting age, education, gender, ApoE4 genotype, all the cardiovascular issues, depression, all are related to risk for Alzheimer's as well as mild cognitive impairment. So our question was, is it the same for Hispanics? We looked at 2 separate cohorts. You've already heard about the TARP. Our group has been enrolling Hispanics and non-Hispanics since the inception of the study. And then this is a rural study that I created when I was still at Texas Tech. So, age. Well, okay, good. We have some consistency there. So, advanced age, increased risk for cognitive impairment. Great, at least we know something. Gender. Okay, well, yep, it's important for non-Hispanics, but not important for Mexican American. Education. Uh-oh. Non-Hispanic, nothing among Mexican Americans. Okay, well, let's look at cardiovascular issues. Okay, so we've got some dyslipidemia stuff going on over here, diabetes stuff going on over here. Okay, so basically what we have is age. That's really not very comforting. So basically the literature is interesting. So with the exception of depression, there's no real consistent risk factor for MCI diagnosis aside from age among Mexican Americans, even though there are thousands of articles published on what are the risk factors for mild cognitive impairment. So basically the literature is great and it's irrelevant to the population that I work with most. So why is that a problem? So education, this is one that is of interest. In what it turns out, we're doing some follow-up analyses with this. And what it looks like, so many of you may know this, so the education attainment varies by race and ethnicity in the United States. That's, we all know that. The average education of Mexican Americans who are English speakers, well, is around 10 in the United States, 8 to 10. Drops down to anywhere between 5 and 6 Spanish speakers. So there's this interesting dilemma. So when does education become protective against cognitive dysfunction? After 8 to 10 years of education. So what we have is a population, a societal issue of lack of education, keeping folks in school to fail to reach sufficient protection in terms of how education is going to be protective against cognitive dysfunction later on in life. So what about metabolic issues? There's a huge literature linking metabolic disturbances to risk for Alzheimer's disease. And if you look, so obesity, interestingly enough, midlife obesity is related to late life. However, in the Alzheimer's world, actually, pre-incident case, pre-diagnosis of Alzheimer's disease, actually most of these patients are losing weight. That's because of muscle wasting. So you see a decline in body mass prior to diagnosis. About 1 unit of BMI a year with this 25% increased risk. So obesity is associated with a whole bunch of things. Hypertension, hyperlipidemia, diabetes. I'm going to talk about biomarkers later on. So adipose tissue, fat tissue is in itself an inflammatory organ. It produces inflammation in addition to spurring on inflammation elsewhere, particularly some markers that are known to be related to risk for Alzheimer's disease. Diabetes. So this is one of those things that I could just keep going. There are probably 1,000 articles on this, at least, linking diabetes to Alzheimer's disease. There is a very well established but very poorly understood link between diabetes and Alzheimer's disease. And it's actually of all the cardiovascular risk factors, midlife diabetes is the most important risk factor for late life MCI, Alzheimer's, dementia, etc. But exactly why that is not positive, but there's a basic pathophysiology. Something's going on with diabetes being related to cortical atrophy, the microvascular changes, etc., etc. So this gets me into why I think the disease, the underlying mechanisms may actually change. So what I'm going to explain here is why I think the disease of Alzheimer's disease, the mild cognitive impairment, why I think it looks different by ethnic groups. And it's not just Hispanic versus non-Hispanic or African American or Asian. It's about risk factors. I don't think the fundamental biology varies in any way, shape, or form. What I think is the relative weight of these underlying risk factors changes. Why is that? Because the prevalence of the risk factors change by ethnicity, socioeconomic status, etc. So this is a very simplistic model. I could add, as a matter of fact, when I started, I think I had 3 times as many bubbles and thought that that was just cruel and unusual punishments to your eyeballs. So I just kept a few. So environmental issues, psychiatric conditions, education, cardiovascular disease, metabolic factors, A beta and tau, that's the plaques and tangles in the brain, traumatic brain injury, genetics. All of these have been linked to risk for cognitive dysfunction, Alzheimer's disease, mild cognitive impairment. So psychiatric conditions, depression, neuropsychiatric issues. Dr. Salazar showed very clearly a linear increase of neuropsychiatric issues by normal controls, mild cognitive impairment, Alzheimer's disease. I just showed you, I didn't show you the pretty picture. I should have, it actually works better. But depression clearly increases. Education. There's a large literature linking education to cognitive reserve protection. Just as a sidebar, education does not protect you against Alzheimer's disease, okay? It protects you against diagnosis of Alzheimer's disease. The more highly educated individuals simply have more, I guess you could say, brain power to deal with more disease. It just takes longer for their symptoms to show. They still have the disease, it just doesn't show. What happens to really high educated people who get diagnosis? They decline faster. So it's a double-edged sword. You may not get diagnosed till later, but then you decline faster. Cardiovascular disease, hypertension, very, very large literature linking blood pressure issues to late life risk for Alzheimer's disease, etc. And why is that? Well, one reason is because basically anything that's bad for your heart is bad for your brain. And if you're having vascular issues, you are probably having vascular issues in the brain as well. And so when you have someone who's had high blood pressure all of their life and you get a brain scan on these folks, you can see the very minute brain insults due to these long-standing cardiovascular issues. Metabolic, I mentioned diabetes just a moment ago. Other things like insulin resistance, metabolic syndrome, etc. A beta and tau, I think I'm going to leave that alone because, you know, yes, the plaques and tangles are associated with the disease. Absolutely. Whether they're a cause of or consequence of the disease, that part is not really firmly understood, though we like to present it that way. Traumatic brain injury. Many of you have seen the stuff going on regarding NFL players, football players with chronic head injuries being increased. They come to autopsy and look like Alzheimer's patients. There's a huge literature on this. This isn't new. It's caught attention because of the NFL issue lately, but even soccer. Those of you, I mean, my guess is there are a lot of soccer fans in this audience. Chronic heading of a soccer ball actually is associated with little small brain changes over time. But traumatic brain injury in general increases risk for Alzheimer's disease, but it increases risk for just about everything. So if you can avoid it, yeah, that's a good idea. Genetics, not anything you can do about that, but we'll discuss some more. Environmental issues, where we live impacts our health, plain and simple. If you live in an area that is all kinds of things like chronic stress, chronic noise, pollutants, groundwater pollutants, rainwater pollutants, whatever, pollutants in the food, less healthy diets. All of these things increase your risk for all kinds of bad health issues. And we know that environmental issues vary by socioeconomic status and ethnicity. So here's how, so here's where you get this is just kind of a bland scheme linking. Well, now this is reflective of the relative weights of where the data is for this sort of risk factor. So among non-Hispanic whites, I just showed you, ApoE4, much more prevalent. So the weight of this particular risk factor is heavier. It's not that it's different. I didn't draw a different line there. I just increased the weight of the line. Cardiovascular disease, why did I increase the weight of that line? Because non-Hispanic whites have higher risk factors for high blood pressure than do Mexican Americans. If I did one for African Americans, this line would be even larger because African Americans have higher risk for high blood pressure than do non-Hispanic whites and Mexican Americans. Metabolic, I made it smaller because Mexican Americans and Hispanics have higher risk for diabetes, etc. A beta and tau, I made it much larger because we simply have absolutely no idea what A beta and tau look like among minorities. It's not that it's different. I have absolutely no idea. This just means that all the research that's been done is among non-Hispanic whites. More than likely, it's this. Yeah, it's there. It's probably, my guess is, less common. Traumatic brain injury. The reason I made it smaller is because what ethnic groups are at more risk for traumatic brain injuries? Minorities in the United States as well as globally. Genetics, environmental issues, smaller. So now, here's what I think it looks like when you work with Mexican Americans. It's not that the biology changes. I didn't change anything in here other than the relative weights. So the genetics got smaller. But it's still there because ApoE4 is still there, as is TOM40 and the other genes. Metabolic got bigger. Why? Increased risk for metabolic issues. Cardiovascular disease got smaller. Education got bigger because we found no protective effect of education. That's a big issue. Environmental. I put question marks here because there's just not much literature looking at environmental by ethnicity issues for Alzheimer's disease. However, we're looking at it now, and I have absolutely no question that there's going to be something there that we need to understand. Then you get to depression. I already showed you also data showing increased risk for depression. So, again, this, in my mind, at least, is a simplistic way of explaining why the risk for why the disease may actually vary by ethnic groups. And if I were going to change by ethnicity, I could actually put Indian here, Asian Indian, and you'd have same metabolic. If I put Native American, same metabolic. Both ethnic groups of Asian Indian and Mexican American, at least with the metabolic profile, would have the exact same, more than likely, the exact same profile here. So, okay, what's the data? So we created a metabolic risk factor, summed up. Obesity, hypertension, dyslipidemia, diabetes, just as a global score, because you saw the data earlier that any one individual really wasn't all that powerful of a predictor, which really isn't all that surprising. And this isn't the best way to do it. We're working on more sophisticated ways of doing this. But the interesting piece was this. I split it by different cohorts, frontier and TARC, by Hispanic, non-Hispanic, and it's only significant among non-Hispanic whites. Is the risk factor. Sorry, went backwards. It's only, the metabolic factor is only significant among Mexican Americans. It's not significant in either cohort among non-Hispanic whites. So what this data says, and I'm going to show you more data later, that there may be more metabolic issues driving cognitive dysfunction in aging and Alzheimer's. And I don't have a clock on my watch broke, so somebody's going to have to tell me when I'm running out of time. You can help me out?
50.
No.
It's 10:50.
I'm speaking to Link.
11.
All right, 10 minutes.
11:15.
11:15?
10.
11:10. All right. Because I really will not shut up. So, you know. Dr. Baldwin's going to throw something at me when I got 5 minutes left. Which will make her happy. All right, so this suggests metabolic issues. All right, so if there's metabolic issues among Mexican Americans, what about vascular issues? So we looked at this, don't worry about it, you probably can't read anything on here. The Hichinsky Ischemic Index Scale, those of you who are physicians have seen this more than likely, and it's just a sum total of vascular issues. Basically, as it turns out when we look at it, we've actually looked at it more in depth, we have updated analyses. But this is a risk factor for mild cognitive impairment only among non-Hispanic whites. It's not predicting risk among Mexican Americans. Here's another, you're going to see some of the same slides between my two talks, but for different reasons. But, so here's, this is a biomarker, random forest Gini plot for the Alzheimer's blood test we've created. But for this particular talk, fatty acid binding protein, CD40, GLP-1, top 3 markers. And then you go all the way down here and you see insulins down here, pancreatic polypeptide here. Those are metabolic issues. Those are metabolic factors. Not the same here. So basically we have data from a biological standpoint suggesting that metabolic issues are more associated with Alzheimer's disease, specifically an Alzheimer's profile among Mexican Americans. And that's the AUC of it. But this really just highlights the same thing. So thrombopoietin in our previous version, MIP-1 alpha, these are vascular inflammatory related interleukins, CRPs down here, in terms of more vascular and inflammatory in nature is where the biological profile of Alzheimer's among non-Hispanic whites is weighted, whereas among Mexican Americans it is more weighted toward metabolic factors. So that's the underlying, so we have the data from epidemiology, we have the data from clinical measures, and now we have data from the basic biology measures to support what we think is going on. Now here's something that, for those physicians in the audience, you may know this, but I was absolutely shocked to see this, and that is comorbidity of diabetes and depression. So among our non-Hispanic whites, comorbidity was 2% among non-Hispanic whites in the TARP. 8% among, that's 4 times as prevalent. Community-based, 5%, 20%. That is a community-based study. 20% of every single Mexican American who came through this project had comorbidity of depression and diabetes. When you combine the two, odds ratio for MCI, 1 point. So basically, you have a much increased risk for MCI with the comorbidity of the two. Even if you look down here where the risk is basically the same, so the risk for mild cognitive impairment, again, going back to the pathway issue, the diagram that I showed you earlier, it's not that the risk is different if I look at this, the community-based study. The risk isn't different. The weight of the risk would be drastically different because you go from 5% to 20%. So for every, basically a 3 times increased risk for having mild cognitive impairment if you have both. So the paradox, sooner or later I have to actually address what the title says. So, despite lower ApoE genotype, MCI and AD, as common or more common. Why? Here's why I think it is. So basically you have a differential weighting. So the ApoE4 genotype, it's important. It's just not as important because it's less frequent. Metabolic issues are very important. The other thing that's a huge issue with regards to the paradox is age of first notice. I can't say diagnosis because it's a community-based study. We go out to the community when we recruit people. And then, so we identify, they're not coming to us to say that they have something wrong with them. But we're identifying mild cognitive issues, mild changes, 10 years younger among our Mexican-American participants than we are non-Hispanic whites. Anyone here happen to know the age of onset difference between non-Hispanic whites and Mexican-Americans in terms of diabetes? Come on, take a guess. I just told you 10 years, so 10 years. It's the exact same difference in terms of onset, just shifted by about 10 years. So about 10 years prior to that, they're being diagnosed in the 40s, maybe in the 50s, 10 years later for non-Hispanic whites. So you basically, what we're seeing, and actually at a recent talk, beautifully presented, which there's someone was diagramming this and showing how basically the metabolic issues are developing at a shifted time, basically 10 years earlier, and what it may be doing is shifting the onset of other quote-unquote aging-related issues earlier. That's a huge issue from my standpoint, is if everybody's going to start developing cognitive issues in their 50s. But this also has a very implications, and this is a sidebar, but it has implications for future incidents in terms of population base. So what's more common, metabolic issues, right? We're relating this to diabetes. What's the fastest growing epidemic in kids right now? Diabetes. So if this literature, these findings tell us anything, is that, oh, guess what? The age of diagnosis of onset of these cognitive issues may actually shift younger in our next generation of kids if you don't do something else. So that's just a sidebar. Perk you up in the morning. So how might this impact treatment options? I'm going to cover this very briefly, and I'm going to stop for questions. But this is what we've done so far. We keep trying to do the beta amyloid, and every trial fails, but we say it's just the wrong trial. We're going to do it again. Persistence in the face of constant degradation. So if we go to, this is what we've been looking at. Now there are some people looking at some genetic issues. We've tried some cardiovascular metabolic. But if I showed you, go back to the design that I showed you earlier, where would I want to jump in for non-Hispanic whites? Well, if I want to test something with cardiovascular issues, I want to test it in folks who actually have a higher prevalence of cardiovascular issues. If I want to test ApoE4 or ApoE4 genotype, I want to test it among those with higher prevalence. If I want to look at metabolic issues, I want to test it among those with metabolic issues. And as it happens, there are numerous trials already ongoing or completed that have looked at, for example, diabetic medications in treating, preventing, halting, whatever, Alzheimer's disease and cognitive impairment. Some of them have actually been quite successful. The intranasal insulin would be one. So this is just going to be my plea for those who actually work with these patients. Don't use the term dementia. The average physician exam, geriatric patients, is 18 minutes. You're not going to get a cognitive eval in that time, so get a referral if you need to. The other thing is it's disrespectful for the children to sit there and tell you that their dad or mom has changed. It's very disrespectful, same if you work with the African American community. So just be aware of that. It may take you 3, 4, 5 visits before you actually get really what's going on. Sorry, that's the way it is. Informant report. This is a big issue about, because if you're going to discriminate between Alzheimer's disease and mild cognitive impairment, you have to know how they're functioning, and this is a big deal. You're likely to get more affective complaints, particularly depression and anxiety. And our data, what we've seen from looking at some retrospective chart reviews, things that I think these patients are being diagnosed with psychiatric, quote-unquote, dementia due to psychiatric issues inappropriately. Okay. Any questions? Yes, ma'am. All right, Gary.
First question is that it actually seems like we see something similar in the VA population, in that we tend to have much higher levels of metabolic issues and vascular issues together, and not actually differing based on ethnicity. So we see people presenting with dementia and much earlier than you would if you dealt with a community-based population.
Yeah.
So I'm wondering if that would be an interesting community versus another type of population, where that we would kind of look at those things to see if really that metabolic issue is what's driving people to look older when they are technically.
Absolutely. I think that working with our veterans is probably one of the best places you could possibly try to study how treating vascular and metabolic issues in tandem can slow issues, prevent issues, treat these dementia syndromes. I couldn't agree with you more. The DoD, for example, is now starting to become interested in those sorts of things. So I think it's going to happen soon enough. It just hasn't happened yet.
This brings me back to my original question or concern about prevention.
Right.
And I see this as a huge discrepancy with Mexican Americans and the modifiable factor
Absolutely.
of metabolic syndrome leading to Alzheimer's disease. It's a great area, huge area for prevention.
Absolutely.
And we've given anti-diabetic drugs over the years, and we've seen really not a whole lot as far as curing or helping, and less focus on nutrigenomics or nutrition and
Right.
treatment, micronutrients in
Sure.
these population and treating them at the cellular level. And I think if we reach down or dig down that far from a functional medicine perspective, that and studies have shown that going that far have great
Right.
promise as well. But I don't see an emphasis on
So
that at all.
one of the reasons why you'll see folks jump when they say prevention isn't really proven, et cetera, is because of the 2011, I believe, 2010 NIA report that came out that officially says there's no data, there's no prevention for Alzheimer's disease. And they're correct, they're absolutely correct that the data does not, at this point, firmly say that if you do this, it will prevent the disease, because there are no clinical trials that have been efficacious. However, I take the stance of there's a huge epi-literature, but there are two recent findings that now make all that epi-literature, that retrospective, longitudinal, community-based work actually hold more water. And that's out of Suzanne Kraft's and Laura Baker's work, who they just actually moved to Wake Forest. But they recently showed, and you can look these amazing articles, they showed that through physical exercise, you can actually fundamentally change the pathophysiology. You can change the biomarkers in the spinal fluid of Alzheimer's disease by exercise. You can also change the biomarkers of Alzheimer's disease and the cerebral, so through the lumbar puncture, through diet. And they're the first to truly show a fundamental shift in the pathophysiology. That's why, right now, there's a national study ongoing through the Alzheimer's Disease Cooperative Studies, the ADCS, on a prevention for an exercise trial. There's also a prevention trial starting with beta-amyloid agents. There's prevention studies ongoing right now for exercise at UT Southwestern, for example. So it's moving forward. The research is now moving forward. I personally believe that we need to look at these prevention efforts, really dig down into the populations also, though. Not just, because all these studies are being done in clinics, in specialty clinics, which means that all the folks that I see will never see one of these studies. And the NIA actually just had a request for information posted on how do you enroll minority populations in the clinical trials, because it is a huge issue noticed by pharma, by NIH, by everyone, that we don't get minority patients in the clinical trials. So it's starting to move. There is momentum, but I still tell everybody, my patients, when I go out in communities, you know what, I don't really care if the data says it's going to prevent Alzheimer's disease. The data suggests it at least is good for your brain, so do it. And the best way to remember it is, if it's good for your heart, good for your brain. Everything that's good for your heart, good for your brain. And then just add on the extra pieces of the mental stimulation, social engagement, etc. Okay, any other questions? I think I'm like running out of time. Yes, sir?
So instead of using the word dementia, what word should we use?
When I do this normally, I say things like memory change, changes in thinking abilities. So that can be very specific. I'll say, and I'll spend more time. So your father's language skills, so he may not be able to find words like he used to. That can change. That, one, it's more concrete. It allows people to really understand what I'm talking about. But it also is just, it's not pejorative. Yes, sir?
Is there any median lifespan difference between the Mexican American and non-white?
So life expectancy, the interesting piece, so Hispanics in the United States are actually the youngest population in the United States. They're also the fastest aging segment of the population because they are the youngest and they're growing at a rapid rate, which is why the fastest growing segment of the aging population in the United States are Mexican Americans. So the life expectancy is also increasing.
Lifespan.
Lifespan, right. So the life,
Is there any difference between the lifespan?
it's pretty comparable now, but I don't have that data off the top of my head, so I'm not going to lie to you and make something up. Somebody else might have it, but it's close, but I think there still is a discrepancy. I do still think that African American and Hispanics, I think there's a slight difference still, but that's changing. Okay? All right, thanks, and I'll see you again in a few minutes.